Thank you very much, and thank you so much for the invite. So in 2014 and 15, there was the largest epidemic of Ebola the world has ever seen around that spot there, and I was privileged enough really to be part of the Australian government response to that, and that's mostly what we'll be talking about today. I'd like to start with some acknowledgements. I do have other photos of Andrew that are perhaps less flattening, but I thought that was the best one to put. This is really to acknowledge the many people at this hospital that trained me and mentored me over many years. I think this hospital and this university are really special places, and I remember them very fondly, not least for the amount of mentorship and training I had here, but particularly for the values I learned here and the values that Andrew and the late Professor Jack Alpers taught me and have stayed with me today and made me very much professionally the person who I am. And so I'd like to acknowledge the many people, not just these two people up on the wall who've helped me in my career, and that really began here. It's a great hospital, a great university, and I feel very privileged to be asked back. So it all began here. Gwekdao is a city in Guinea that's a shanty town, really, and it grew up as a place of refuge. Sierra Leone had recently had two civil wars, very nasty civil wars bad enough to lead to war crimes tribunals. Guinea had also had substantial civil wars. Liberia is relatively peaceful. And so this became actually a place of refuge for people from very nasty civil wars in the 80s and 90s. Very populated. There's a weekly market there. And the population went from about 80,000 to 250,000, which is about twice the size of my town, over a very small period of time with very little infrastructure. And its population almost doubles every week because there are traders from southern Guinea, Sierra Leone, Liberia and the Ivory Coast. So perhaps not the best place for this little boy to get sick. Emil was 3 and he died of a rapidly progressive febrile illness in Gwekdao in the Milandio village in December 2013. His mother, sister and grandmother then became ill and died, and it was not recognised initially as Ebola because there had been really very few or just one outbreaks of Ebola on the West African coast. Ultimately, the primary source of infection was identified as bat, cooked as bushmeat, and so commenced the 20th major outbreak of Ebola, and the first that was really seen as a major outbreak in West Africa. The important thing about Ebola is it's a zoonosis, and there's a reservoir animal infection which is in bats, and it causes minimal disturbance. It causes bat flu really, and at any one time perhaps 3 to 10% of the bat population are infected. If you do post-mortem antibody studies on bats, you will find antibodies to Ebola in about 10%. And it doesn't actually cause an illness, it just cycles across there quite harmlessly, but there's episodic transmission across a species boundary. As I said, nobody's actually directly detected the viral RNA in bats, but you find specific antibodies in about 10%. There's quite a geographic and species distribution, and there's paleological evidence that it's actually quite an ancient disease. And bats are an ever-present reservoir. And the importance, of course, is that Western and Central Africa are protein poor. Why would you eat a bat? Well, because you have to, basically, and therein lies the problem. So with that background, Emil became sick in December, and then there were 12 further cases of severe vomiting diarrhea with a high case fatality, further deaths in this province here, Macenta, Nzakore developed a few outbreaks, as did Kisegao, and so MSF, who are always first on the ground in these situations, they have the greatest experience worldwide in terms of just gloves on the ground with Ebola, and the Sri Lankan Ministry of Health teams were mobilised in 2014. And this is the first paper that came out that described 15 cases across those provinces, largely fever, diarrhoea and vomiting. This is the world's worst gastroenteritis. Virtually all of them died. It's generally untreated, about a 90% mortality rate. And at this stage, the virus is only isolated in a few patients because the PCR laboratories were not necessarily up and running at that point. And then we saw this takeoff. We saw this takeoff in 2014 up to a peak incidence of 600 cases per week in Liberia, around 600 cases per week in Sierra Leone. Interestingly, not the same in Guinea, because the US military had a presence on the ground, and so their response was much quicker, but a very rapid, exponentially increasing, incidence over the latter months of late 2014 and early 2015. So at its peak, the region was getting 1,400 new confirmed cases per week, and the total epidemic when I last accessed was 28,500 cases with 11,000 deaths. Not all of those were confirmed. They were those that were probable suspect and confirmed. Later on in the epidemic, the virology was such that you could do a yes-no answer on all of those patients. It was initially declared ended in 2017, but then, as often happens, in January 2016, there was a further case detected on post-mortem swab, and there were probably 150 contacts related to an unsafe burial. Finally, the public health emergency of international concern was closed in 2016. Okay. In all cases of Ebola outbreak, there is an animal to human index case. And that's either bats or non-human primates. And again, people come across a dead gorilla in the bush, and you eat a dead gorilla because you're hungry, and that's a protein source. Then there's human-to-human transmission, and that's incredibly efficient as this virus goes. It's excreted into bodily fluids, including sweat, so it's on the surface of the victims. It's associated with very high volume gastrointestinal fluxes, so there's a lot of vomiting and a lot of diarrhoea. The bodily fluid has a high viral load at death, about 10 to the 9 copies per microlitre. It's transmitted by droplet, person to person, fortunately not aerosol. In an aerosol, the particles actually dry out, and that desiccation renders them non-infective. If it was able to be transmitted aerosol, it would be horrendous. And viable virus lives on fomites for up to about 36 hours. So it's a relatively fragile virus. It just happens to be transmissible in a very rapid sense from person to person. The transmission factors, of course, relate to both the virus and the protoplasm. A small inoculum, a picoliter, is enough to be pathogenic. The entry is not via intact skin, it's via mucosa or skin breach, and of course there are a lot of people with skin breaches in West Africa, and viral replication, as we'll see, is associated with very early host immune paresis. So it's the primary trophic targets the virus are immune effector cells. And of course the patients have a lot of comorbidities in the African context of HIV, malaria and poor nutrition. Probably more important than the biology, though, is the societal factors, because it's overcrowded. It's almost universal for people in Africa to have chronic skin diseases and chronic skin infections, so there are many portals on the skin for entry. There's rudimentary basic hygiene and often a poor to non-existent sewage infrastructure. Sierra Leone was just recovering from, as I said, 2 really nasty civil wars, and so there's not a lot there to prevent spread. And funeral practice involve ritual washing of deceased remains and sometimes drinking of the fluid. And so that was an absolute perfect storm for it to transmit. I suppose you can think about this in 2 ways. This is the town that I'm privileged to work in, and the road I drive every morning to work is down through this lovely hill, through these amazing buildings, and this is the wonderful facility in which I work, and in a small regional town, I have everything I could possibly want for as an intensive care doctor and as a chest physician. This was the view out the bus on the way to work in Sierra Leone, and this is their main public hospital. And it's not easy, it's not difficult to see why these sorts of illnesses will flourish in that environment. We would control Ebola in Western society in an instant. It would not be an epidemic. It would be easy to control in a way that it isn't in that environment for obvious reasons. If you look at health spending per head of population across the world, of course the highest is in the United States, closely followed by Western Europe, Canada and Australia and New Zealand. And in the areas we're talking about, less than $25 per person per year. So there's not a lot of infrastructure there. And so we saw, again, that exponential increase in cases over that time. So what happened with that is that the World Health Organization issued a public health emergency of international concern, and that was number 3 out of so far 4. The other ones have involved recrudescence of polio, the Zika virus, and I forget what the other ones. And we are a signature to that, and it gives us, as Australians, a legally binding obligation under international law to give assistance. And international disaster response laws, the summary is there's a need for prompt international assistance. Foreign teams and actors are in country at the request of the affected state, and they maintain sovereignty and responsibility. This has been going on for a long time, so these guidelines and principles of international aid date back to 1875, when the then Red Cross, and now Red Cross and Red Crescent, established the initial principles, and they've been ratified in UN and ICRC charters. And what is clear is that every nation has the right to seek assistance when faced with disaster, and a right to life with dignity and protection and security. And we have something of a soft legal responsibility as signatories of that to provide aid where possible. And that was probably happened a little slowly. In the end, there were lots of people in there. Médecins Sans Frontières are always first up with this. They've done virtually all of the Ebola epidemics before, and they have the greatest responsibility. Save the Children ran an Ebola treatment centre, as did Partners in Health, who had some interesting treatment ideas, particularly emergency, and an Italian group I'll come into. But we basically, in Australia, piggybacked onto UK aid. And the UK were big players in Sierra Leone. During the Civil War, during the Second Civil War, they came in as unarmed peacekeepers. And the sort of things they were seeing were so bad that within about 30 seconds, I think, they actually became armed peacekeepers. And somewhat uniquely in the history of international conflict, the entire population said, oh, thank God for that, we are so over this. And they went from being a very conflicted society to one of the most religiously harmonious and tolerant societies on earth, to the point where there would be Muslim prayers and Christian prayers offered at the beginning of each day at the hospital, and people would sort of oscillate between the two. It was quite extraordinary and quite spine-chilling. They are very decent people. So they were already there, and they have a big presence, and they basically welcomed us into their operation. We were awarded UK diplomatic status and privileges, which, as Andrew knows me, would be quite interesting thinking of me as a diplomat. Doesn't really quite compute. Our Ebola treatment unit was built by the Royal Engineers, but all of our stuff came from the UK, and we opened in 2014. That's where we were, on a disused airfield. Basically, that was levelled off, and all of that is just a tent city, but pretty up-spec tents, and that's what the design looks like. If you look at the design of an ETU, they're all pretty much the same. So there's a white zone, which is sort of admin and where security and people sit. There's then a clinical zone that you enter, and a green zone where you are basically sort of semi-dressed for work in scrubs and boots. And then there are ingress and egress points between the red zone and the green zone where the patients sit. We had 100-bed capacity. and at our greatest, I think we were running about 50 odd beds. There were 2 100-metre water bores, and 100 metres is a bloody long way down, actually. That's a big deal to dig that. And we had reticulated chlorinated water, and the virus is actually very sensitive to hypochlorite, and we had 2 concentrations, basically. That's really what it looked like. So I think it was called grit rock because there was gravel everywhere. The gravel, by the way, you would drive to work and you'd see people actually making gravel by breaking rocks. That's how they made the gravel, and that was in our hospital. And you sort of reflect, gee, how much would you have to do to feed your family that day? It was quite disturbing, really. There is somebody in the green zone taking a picture of notes from, I think, me having done an entry. So there's nothing that goes back and forth between the green and the red zone that isn't decontaminated. We had our own generation. Most of our stuff was disposable, but obviously the boots and gloves, particularly for the Watsan staff, were non-disposable. The virus is killed very quickly by ultraviolet light, and there's plenty of that in Africa. When you start in an Ebola unit, the primary emphasis is on keeping yourself safe and infection control. So how are you going to actually see people and then come out and stay alive and not get killed by the virus is the primary thing that the unit is designed for. And then you build the clinical care on top of that, not vice versa. And that was the hard thing to get your head around. As I said, MSF have had the biggest experience of this, and so they were the protocols that everybody was using. We had 100 physical beds, and our peak caseload was 33 patients and 23 confirmed Ebola, and that was chaos. We had staff who provided clinical care, obviously, sort of gloves on the ground. There were health promotion staff who did contact tracing, and in particular tried to reincorporate the survivors back into the community, which was difficult. There were 4 in-country expat doctors at any one time, 3 to 4, and 20 expat nurses assisting about 80 nationals, and 3 environmental health officers who were the really cool guys. They kept us safe. They basically knew how to make sure our food was safe, make sure that the chlorine was working properly. And there were about 80 Watsan staff that they supervised, logistics and support, and it was pretty lean. There's two of my good friends there with one of our survivors, and these are all survivors who are basically out there doing health promotion. So the goals are to identify and cohort at-risk patients and to prevent transmission back in the community. So if you get the patient out of the community, then you have reduced that the ability of that person to actually transmit the disease. But other patients across the zones, because not everybody who's admitted is clearly infected, and to staff. And then once you've done that, you build care that pushes the patient towards survival, good symptom control and palliation, a safe and dignified place of refuge for the terminally ill, and what was very important was to do safe but dignified management of the deceased, because it was very important for the families that they felt when somebody came in that if they did die, their remains would be looked after in an appropriate fashion, consonant with their beliefs and their practices. And so that was a big part of what we did, so that we could get people in there and get a reputation. There was a central command centre run by CDC and the Sierra Leone Minister for Health. And we had both walk-in referrals and ambulance referrals. All of the ambulance referrals were admitted. There was a network of about 20 Ebola treatment units across Sierra Leone, across the west where the epidemic was. And there was a fairly random allocation of patients by the command centre. There was an expat assessment unit run by the Brits in Kerrytown, so that's where we would go if we developed an Ebola-like febrile illness and be sorted out. And there was a specialised obstetric facility run by MSF Spain, for which I was extremely grateful, because I'd last delivered a baby 30 years ago. And I remember on the flight sort of reading about their obstetric protocols, and I thought, what have I got myself in for? I'll talk about an ICU facility operated by some Italians. And we had weekly meetings of foreign medical teams, which were really interesting. So we all talked about our experiences and information was shared, but there was no formal standardisation of care. Safety. So for safety, there are entry and exit protocols. Patients are cohorted in the red zone to suspect, probable and confirmed, and you basically, confirmed means they're PCR positive, probable means they tick more boxes on the case form than the suspect. And when you did your ward round, you moved to areas of escalating risk and never back. You're always supervised putting on your PPE, chloride ions everywhere, and you were always in a group of 2. And you could manage 30 to 40 minutes into the red zone because it was just so hot. You're in a hazmat suit and an apron and gloves and 2 masks and things. And the last thing we wanted was a person, have to activate a man-down procedure in the hot zone. So basically there would be a horn and you must come out, no matter what the problem was. And that's hard. So all of that's collecting the PPE. There's me all sort of dressed up in it. It's a compulsory picture to have when you do it. So there's a hazmat suit, a hood, masks and gloves, and you do it according to a protocol, and it's observed and assisted, and we went through 10,000 a week in protocols. This is the more critical thing, which is taking all the stuff off. And basically you are sprayed with a garden sprayer with chloride to within an inch of your life. Take off your first pair of gloves, wash your hands, and then spray it again, and then take off your apron. And there's this very loud African voice abusing you if you don't do it right, basically, so it's impossible to get wrong. And we were assessed in that before we actually went in. And I am actually hopeless at PPE. I suspect Andrew would remember that. And if I can do it, anybody could. We had over 10,000 red zone entries in our unit of people going in for a variety of things. Doctors, sanitation workers providing food, doing nursing care, all of those sorts of things. There were up to about 25 confirmed Ebola patients on each entry. Towards the end, we were routinely sticking IVs in. We did 45 body retrievals. There were 2 PPE breaches with a potential exposure, and both those people went off to Royal Free London for assessment, but neither of them developed Ebola. And we had 2 staff admissions to Kerrytown, which is the healthcare worker ETU, and both of those turned out to be febrile illnesses, not Ebola. And in 10,000 red zone entries, there were no transmissions or acquisitions. So it is fundamentally safe. I'm somebody who likes my creature comforts, and I missed my creature comforts, but I was never in danger. And that's the important thing, is that you can do this safely. To the point now where in the vaccine trials, it's a waste of time doing a trial on healthcare workers because healthcare workers do not get Ebola. We are that good at it. There was positioned in the bay for us a Royal Navy casualty receiving ship called Royal Fleet Auxiliary Argus, which was a hospital ship that had a couple of a CAT scan, a couple of operating theatres and an 8-bed ICU. And sadly, everybody wanted to go and have a bit of a look, but the Brits were fairly tight-lipped about all of that and wouldn't let us go on unless we were sick. But that was there for us if we did get sick. So we were well looked after. How do we do clinical care? The whole environment limits what you can do. So there's lots of hypochlorite ions around, and electronic monitoring just dies. So a blood pressure, a non-invasive blood pressure machine might last a few days until we worked out how to wrap it up. A pulse oximeter wouldn't last that long. So you couldn't really do much. You can't use the stethoscope because you can't put it between your ears. You can feel the tummy, you can percuss the chest, that's about it. We didn't have X-ray or ultrasound. We didn't have haematology or we certainly didn't have micro, blood transfusion or organ support. What we could do was do a PCR test with a 4-hour turnaround, which is just amazing. When did you last do a PCR and get a 4-hour turnaround? And we had malaria serology, and we were subsequently able to do some blood tests, so some electrolytes, liver tests and renal function and stuff, but not much. Okay. The clinical manifestations are gastroenteritis and volume depletion. They get a very nasty mucositis and conjunctivitis and hiccups. Those two things seem to be a really poor prognostic sign. Develop an encephalopathy. Ebola has been referred to as a hemorrhagic fever, and in previous outbreaks there was a very marked coagulopathy associated with it, but that didn't seem to be the case here. Myalgia progressing to rhabdomyolysis and sepsis syndrome. There's a case management flowchart, of which a very brief version is here for your interest. But basically we would triage people as suspect, probable, or they might come PCR positive as confirmed. As I said, no backward movements across the zone. And we would say somebody was Ebola free if they were a suspected case but had a negative blood PCR 72 hours after 72 hours of symptoms, or if they were a confirmed case, we would say they were cured if they had a negative blood PCR after 72 hours after resolution of symptoms. And that's the empiric choices that we made. These are the original 2008 guidelines from MSF that we used. The care was very conservative. There's no question of organ support. And when we started our unit, nobody was really even putting IVs in. The wisdom of doing that was considered questionable. It was basically said to be very dangerous. We were told that if you put an IV in somebody with Ebola and you stick yourself, you're as good as dead. You will not survive because the inoculum is so high. Now, I'm not sure that that was true, but that did rather focus the mind in the initial stages. So we would progress relatively early to palliation, but there was a strong emphasis on this, oral rehydration therapy. Then in February, there was a report via the Sierra Leone Ministry for Health, and that appeared in the New England Journal. And they reported 581 cases, confirmed cases that they treated, with a very extensive treatment protocol. It doesn't quite project, but they were giving intravenous drugs, intravenous fluids, oral antimalarials and oral rehydration solution, and claimed and published in the New England Journal a 73% survival. The problem was that nobody believed it. That unit was across the road from ours, and they would run out of bed linen and ask us if they could have some bed linen, to which the answer was, yeah, sure, of course. But it seemed inconceivable that they were doing that and nobody else were. And so when that paper was published, everybody basically shut up shop and no one published anything further for a long time. And there's still not a lot out there in peer-reviewed literature on the outcomes of these patients, largely because of that paper. And it would be wrong to call it research misconduct or fraud, but I'll leave you to draw your own conclusions. It was very damaging. So for the first 2 months of our unit, it was just oral treatment, and we then commenced IV fluid resuscitation, gave IV antibiotics, antimalarials, hydrocortisone in desperation, really, oximetry. We learned how to use oximetry and we rolled out some oxygen concentrators. And so our mortality was 52%, or a survival, if you like, of 48%, which was about on a par for most other units, okay? I did a death audit while I was there. The clusters of mortality and survival seemed to correlate with family, but there are about three different surnames in Sierra Leone, so it's a bit hard to tell, but as far as we could tell, that was the case. A high viral load was predictive of rapid demise. There were sudden deaths, might have been potassium, didn't know, couldn't do electrolytes until later on in the mission. I think a few people presented with mucositis and they just presented with upper airway obstruction, some abdominal pathology with abdominal pain unspecified, an encephalitic picture with seizures. I had one person just had a fit, and by the time we got some anticonvulsants into the unit, they were dead, and progressive sepsis. There were one group of absolutely bonkers Italians who were doing intensive care. An emergency is founded by Gino Strada, who's a cardiac surgeon. And so it's probably worth a bobble too. But that is a big NGO, and that provides free and high quality care to all victims of war without fear or favour. And their basic philosophy is if Western medicine's good enough for us, it's good enough for everybody else, thank you very much, and we will not compromise. We will provide the same standard of care in any environment on the planet, and there will be no compromises. And they run surgical centres in Sri Lanka, and they run a cardiac surgical hospital in Khartoum in Central Africa, which is really cool. They do multiple valves and congenital heart disease with a 90% one-year survival. They are really good operators. And so they were able to provide full supportive therapy at 2 Ebola treatment units. And they were purpose-built, enclosed, and so air-conditioned down to 21, so you could stay in your PPE for up to 3 hours at a time, as you could actually live there. They provided mechanical ventilation, hemodynamic monitoring, and even were running hemodialysis, so running extracorporeal circulations of Ebola-positive blood on all comers. And of the people they ventilated, they had a 52% overall survival. Interestingly, they were often very disabled at discharge, and their ultimate fate was unknown. So they could do it. And it's very interesting philosophically what you think about that. At the end of the day, what we needed when they were operating were beds, because there were people dying in the street, there were bodies on beaches, and there were bodies at odd angles at all places in our unit. We needed more beds, and a lot of resources were going into a few patients. It's an interesting ethical discussion. If you go to a resource-rich country, of all of the people who have been repatriated, 81.5% survive. So it is a survivable illness with support. Our difficulties are there are long periods without supervision or care. So the patients are in the ward and there's no healthcare worker in there. They're just left to their own devices, basically. There's a heavy reliance on self-directed oral rehydration, so you have to get the patients to do it, and you would ask the patients who were more well to assist the patients who were less well. Some units actually had Ebola survivors staying in the units without PPE, because once you've had it once, you don't get it again. The PPE is obviously very limited. Our drug supplies weren't bad, and the disease itself is difficult to treat. The other problem is that the survivors were stigmatised and were shunned by their communities, so it was very difficult for them to reintegrate. And one of the things that our health promotion officers were very good at was trying to get reintegration. There are lots of conspiracy theories. I'll come on to those. We often discharge children as orphans. The deceased body management is difficult. This was really important to safely retrieve a body from the hot zone into our mortuary. And that was managed and supervised by doctors. That was basically just a responsibility we thought we'd take. The nurses didn't want to do it. The environmental health officers did, but it was considered an important and dangerous thing to do. And you would spray the body and put in 2 body bags. And we worked out a way of allowing families to view the body whilst minimising the transmission risk to others. And that was a confronting bit, and there are still memories there. Why is it so lethal? Well, it's a highly virulent virus, and it has multiple organ targets. You get a very high cytokine response, large gastrointestinal fluxes. There's a microvascular viral target I'll come on to, a lot of secondary organ failures. So it's a highly virulent organism. The patients are not well, and the resources are not great. But it is largely, its first target is immunology. So it hits the dendritic cell, which is involved in antigen transport to T and B lymphocytes, and it inhibits interferon production. And so it means that there is no adaptive immune response, or the early adaptive immune response is very poor. It wipes out neutrophils, it wipes out macrophages and natural killer cells, and it hits multiple other cells within the body. So it's a virus that hits many mammalian targets. So the vascular endothelial cell, the liver cells, macrophages, just about everything gets wiped out. There are some limited post-mortem studies. Unsurprisingly, pathologists were not lining up to do post-mortems on Ebola victims. But one of the things that's seen is a lot of pancreatitis at death, a lot of adrenal hemorrhage at death. It's been known since the 1970s, and this is a landmark paper, that death from infection is the most heritable of all diseases. This was a study that was done on identical twins separated at birth, and if you have had a sibling or a first-degree family member who's died of infection, you are 6 times more likely to die of it yourself. That's more heritable than cancer or just about anything. The immune responses to Ebola seem to be binary. Subsequent to this episode, the bloods have been analysed and there seems to be a survivor profile with these responses and a non-survivor profile. So we see people who are inevitable, non-survivors. This man, I remember well, he came in just like he had the flu. There was almost nothing wrong with him and he almost wasn't admitted, and he was PCR positive, and he was wandering around the unit helping other people until he became negative. He just laughed at it. And so whatever genetics he had the genetics for survival. So the inevitable survivor, the inevitable non-survivor, and the potentially salvageable people who have salvageable immunology but volume loss and shock and organ failure, and they're the people we are trying to push in the right direction. Ebola actually persists in survivors. So they're areas of immune privilege: the eye, the CSF, the gonads and articular cartilage. And this is a case report in the New England Journal of Dr. Crozier, who was a returned healthcare worker from the United States who developed Ebola and received full-on intensive care back in the US for several weeks and survived, had a long rehab illness, and then developed anterior uveitis and had an anterior chamber paracentesis and was found to have Ebola virus actually actively replicating at higher log viral loads than was present at the peak of his illness. So there does seem to be persistence. And we don't know really, I think, how much that will contribute to ongoing disease. There's also a Scottish healthcare worker who was returned, again was Ebola positive. She probably contracted that not at the unit but outside in the community. And she later on developed meningoencephalitis some months down the track with Ebola virus RNA detected in the CSF. She was successfully treated with some investigational therapy. So there is a new reality of an endemic human reservoir with potential for re-emergent epidemic and episodic transmission. Where to now? There is a vaccine, and there is some controversy because the trials are difficult to interpret, but up to 100% efficacy for the vaccine has been claimed. It's a recombinant viral vaccine with Ebola virus glycoprotein spliced onto vesicular stomatitis virus. The initial delivery system was actually needleless, but it's now actually given as an injectable vaccine, and it would seem to be highly effective. And it's now used as a strategy of ring vaccination around contacts, because you get actually a fairly rapid IgG response to that vaccine. There's now a new outbreak, as you'd be aware, in Central Africa, and currently there have been 120 cases with 78 deaths, so still a high mortality, 60-odd% mortality. Ring vaccination has controlled it. Here you can see at peak there's been 50 cases, so much less than we saw in West Africa. Investigational therapies have been used in 20 patients. There are a whole pile of things that were being used in the West African epidemic. So convalescent serum was being used, and that was actually a good trial run by the Sierra Leonean government, which was published and found to be negative. They were using fractionated serum in Guinea, some repurposed antivirals, off-label drugs. The Italians were very keen on amiodarone because biologically it seemed to reduce viral ingress into cells. There may be a specific effect of anti-malarials as part of the sort of higher survival rates that we've seen, and monoclonal antibodies. These are the current hot ones. The World Health Organization is now actually both authorising but also monitoring their use. So these are monitored emergency use of unregistered investigational agents. And the two that are of interest are ZMapp, which are just monoclonal antibodies, humanised murine antibodies made after Ebola exposure. It would seem there was a 40% relative risk reduction when it was trialled in West Africa, but it was stopped as the epidemic stopped. Not significant, but promising, and the only baby to have ever survived Ebola received this agent. RNA polymerase inhibitors repurposed are effective in a murine model. There's no direct evidence, but it's used as post-exposure prophylaxis in Western healthcare workers now, or all healthcare workers. This is a fully humanised monoclonal antibody. I think it's hard to know at the moment how effective they will be. They've been used in only 20 patients so far. And the logistic difficulties are that the monoclonal antibodies require a prolonged infusion and they need a cold chain, and that's very difficult in those environments. There are all sorts of other things that were suggested, including homeopathy. And before I went, I've downloaded this from the net. I saw this in the local newsagent, the New Zealand Journal of Natural Medicine, had a whole thing on Ebola. And when I went in, it was apparently a conspiracy of Big Pharma run on behalf of the Jewish community. And I was thinking of buying it, and I thought, no, I actually can't bring myself to actually spend money that will go back to those people. So I didn't. But that was, that's at one extreme end. This is Bob Katter, and around the time I was coming back, he was saying that we were creating a risk in Australia by doing this, and that's sort of fair enough. But I think the important thing to remember is why you should do this is we've signed up for it as a nation. So these are the international health regulations and the signed parties, and we are there. We signed up 10 years ago to this. So we have a legal and a moral responsibility. This is another tale of two cities. This is the Ebola Command Centre in New York, manned 24 hours a day, and you can see it's pretty swish. This is the one in Freetown where I was, and look, there's computers and there's people there, but you can see who's getting the money. This is where it's happening. This is where it's theoretical, okay? And Jeff Drazen wrote this in a beautiful New England Journal of Medicine editorial that sort of brings tears to my eyes when I read it. Well, he makes the point that we have spent vast sums preparing a local Ebola response for if it happens in this country. It won't. A more effective response is control at its source. The fundamental solutions are turning this into that. So equity, food security, care without borders, population control, attitudes and inclusion, and particularly in this week, research. Research has made a difference. Research has got a vaccine, a recombinant viral vaccine, which is a big deal, in less than 3 years. It's got monoclonal antibodies, which are interesting therapy in 3 years. And the simple research of how to, just descriptive qualitative work of how to set up and run a unit means that people can be treated effectively, treated safely by those who do it, and halve the mortality from 90% to 50%. And that just illustrates what research does in any illness, and this one in particular. Albert Camus, and I haven't read this, wrote The Plague, but a good quote for that is, it may seem ridiculous, but the only way to fight the plague is with decency. So the summary is it's the world's worst gastroenteritis, and this is the place where it will always happen. To treat effectively, you need to realign your priorities, build a unit for safety first, and then run before you can walk. It can be done, and research matters. It's support and attention to detail, just like what I do in ICU and what Andrew's done for many years and taught me. There are now 3 reservoirs: bats, non-human primates, and human survivors. The vaccine is effective. Controlling epidemics at the source is best. And to serve and to do this was a real privilege, to be part of this amazing international response and a tiny little cog in a big machine that did this. I felt very privileged to be part of it. As you can see, war is hell. And that's where we sort of did occasionally get to relax. And I'll close now and ask for questions.